Welcome to our webinar today on crisis proofing communities, how people who use drugs adapt to climate and health emergencies. I'd like to start by acknowledging country, wherever we come from. We're on Aboriginal lands and that sovereignty was never ceded. Today, I'm coming from Wiradjuri country, Bungamburawatha, which is the traditional name for Albury on Mirror, the Murray River. I'm Joelle Murray. I'm the Policy and Evaluation Specialist, and I would also like to recognise that we stand on the shoulders of the peers who came before us, and I'd like to honour those who are no longer with us, but also the peer leadership today. And yeah, we've just got a couple of housekeeping. So you can put your questions into the Q&A function, or maybe the, oh yeah, there it is. And we'll get to those we'll answer those live during the session. And then please keep the dialogue respectful, and a recording will be made available and published on our website and YouTube channel in the coming weeks. Okay, so I would like to introduce our panelists, or get our panelists to introduce themselves and their role in the research. I'll throw to you, Jess.
Thanks, Joelle. I'm Jess Zamani. I'm the research lead with AIVL, and I'm joining from Gamilaroi country here in northern New South Wales. And yeah, myself and Ellie largely were involved in leading the planning and sort of undertaking of this project. And in particular, my role was around sort of the preparatory stages and preparation of the research tools, and engagement to AIVL's membership, who were instrumental in engaging our community of people who use and inject drugs on the ground to receive their input. So we had two main survey tools, one for organizations and one for individuals. And yeah, that was the data collection process, and collation and analysis, thematic analysis. I sort of led in the report write-up, which we've sort of been undertaking now as an AIVL team to complete. So yeah.
Fantastic. Thanks a lot, Jess. And Ellie, would you like to introduce yourself and a little bit about the kind of the background on where this research came from?
Yeah, thanks, Joel. So I'm Ellie. I am the Deputy CEO of AIVL, and as Jess was saying, we were part of rolling out this really exciting report, actually. So this report actually comes from the International Network of People Who Use Drugs, who in 2022 released a global report about the impact of COVID-19 on people who use drugs around the world, and recommendations for the kinds of policy reforms that were needed if something like this were to happen again. They got some funding from the Elton John Foundation and gave it to AIVL to do the same kind of work in Australia, recognising that there were different impacts and different ways that countries responded to the coronavirus that could have like localized impacts on people who use drugs. So it was a small amount of funding, and we ended up putting in a little bit more of our own money so that we could give it to the state and territory member organisations of AIVL, the state and territory drug user organisations, to consult with their communities, as well as talk about what had happened for them as organisations in the response, the kind of impact it had on them as services, as well as the impact it had for the people in their communities who use drugs that they were working with, and to talk about what they thought would be needed if we were to look at this kind of issue in future, if something happened like this again, which we think, like it's likely to happen again. And we expanded it a little bit because, we're Australian and climate change is affecting us in pretty major ways. And we thought that we needed to think about more than just health pandemics, but also those other kinds of disasters that are increasing in our communities, bushfires and floods and the things that we're seeing all the time. So that's what we did. We talked to our communities, and then Jess and I worked with them to talk to their communities, and then we put it all together, and this is the result, the report that we've got asking for some changes and yeah, some reviews of how we do this in Australia.
Thanks, Ellie. Yeah, I mean, one of the strong parts about the introduction is that there's a really strong literature review of research that was conducted about people who use drugs during COVID. So not only does the report have our own commissioned research, but it also provides a summary of other research that was published from that time. Jess, did you want to add anything more about the purpose or the methods before we talk more about the results?
Yeah, thanks, Doc. Yeah, so as Ellie mentioned, essentially, we embarked on basically a three-stage research process. So there was a planning preparatory period where we did basically the literature review and early engagement to our members and preparation of the survey tools, which were available both in paper form and online. And as Ellie mentioned, our services received a sort of bulk payment for both their participation and for payment of individuals for completing the survey. Because, yeah, obviously we are very sort of firm on prioritizing reimbursement, of people who use drugs when it comes to research and in cash form. And yeah, so the survey tool was really focused on collecting services and individuals, experiences and the impacts that arose from COVID. And as Ellie mentioned, I mean, I myself during COVID was living in Northern Rivers where we had the fires, COVID, and then the floods, and certainly the literature review sort of was captured, especially in areas like Northern Rivers where COVID certainly compounded what were already volatile environmental occurrences. And I think it was very much shone a light on the need and pertinence of having crisis and preventative planning and foresight for instances like this, especially given we are in, an era of climate change and volatile weather events. So I think it's really important that as community controlled organizations and peer run organizations, we're taking those proactive steps to engage and consult with our services and community on what the priorities are and how we can respond and and also advocate and lobby government in ways and to influence policy so that we actually get some proactive support there. But yeah, so we had a thematic analysis process after we amalgamated all of the data, and we sort of workshopped that as a team to produce the recommendations which are in the report. So I guess that's the main summary of the methods.
Thank you so much, Jess. Yeah, super interesting. Okay, so we're now going to get to the the nuts and bolts, I guess, of some of the findings or results from the research. Ellie, did you want to highlight some of the kind of overarching findings that?
Yeah, sure. one of the there were lots of things that we saw that had been seen in the literature and also in INPUD's research that they did in several countries and regions. One of the big things that we saw that we hadn't seen so much in some of the other reports is how much our drug user organizations really stepped up during COVID, and that meant that when there were lots of other services, especially some of those frontline services that the most vulnerable people in our communities, homeless people and people with mental health issues and things like that, those services were shutting down or really changing in a way that made it much harder for those people to access them or get some of the things that they'd relied on them for. And our drug user organisations filled a lot of those gaps, and it meant that there was a huge burden placed on them. They had to scale up their workforces really quickly. They had to adapt to COVID at the same time as doing this, with all the, remember when we talked about PPE every second day, it seemed, or maybe multiple times a day sometimes. They were having to navigate those kind of daily changes that were happening during, especially the early days of the pandemic when no one knew what was going on. They some of them increased their hours and even increased the populations that they were working with to make sure that some of those most vulnerable people weren't left isolated and behind. And they did it often without a lot of resourcing. There was a bit of resourcing made available that they talked about being quite grateful for, but it also put a huge strain on the people that were working in those services. So that came out pretty strongly for the drug user organisations that we talked to. But also I think how proud they were of the kind of creativity they showed and their adaptability and flexibility. It made a huge difference, I think, to those local responses, and was really crucial for our community, for people who use drugs that were impacted by the curfews and the restrictions that were being placed on us at the time.
Yes, and the things like NSP continuation, it's particularly in a pandemic, people still need to access harm reduction equipment. It's not like people just stop using drugs because we've got stay-at-home orders. We saw some pretty innovative distribution approaches come into play as well.
Yeah, 100%. Yeah. So we're a lot of people talked about having to change their drug use a little bit. Drugs were more expensive often during COVID. Some drugs were a bit less available.
Oh, Ellie, you've just gone on mute.
I wonder what that's saying about me. But people were definitely still using drugs, and the harm reduction services that drug user organisations were providing were essential during that time. It put a bit of a risk, I think, for the people providing the services because you were so visible out in the community, but they were doing outreach, providing people with their methadone takeaways when people were having to isolate, giving them extra injecting equipment so it could be distributed in local communities, distributing the PPE so that people could provide it, and finding ways to make sure that people got the equipment that they needed in ways that were COVID safe.
Thanks, Ellie. Yeah, really good summary there, particularly around those service level impacts and the way that AIVL members adapted to the changing circumstances. Jess, I'm interested now in talking a little bit more about the kind of more personal impacts and
Yeah,
some
I
of the
know.
pros, some of the cons.
I mean, yeah, I mean, Ellie started to, touch on them, but like, I think, unfortunately, the most vulnerable people are the most affected in circumstances like this, and they're often the most visible, which, in particular, for people who use drugs, create a lot of concerns around police, for instance. Any time where you had to be out and about was a cause for stress. Basically, you felt visible and easily targeted, whether that was on foot or on roads, because of whether that was to do with curfews or having to cross borders, or I was living on Northern Rivers where you had the border not too far away, and yeah, certainly I had a lot of peers who had a lot of stress negotiating that. But yeah, just being out and about, the issues of isolation as well, especially for people in regional areas, but also people in lockdowns in the cities. It meant that a lot of people were using at home alone. And that created a lot of risks in itself, overdose and things like that. And within peer networks as well, though, there were responses, like I know within my own peer network, within INPUD and that, because we all knew we were using at home alone, you sort of did check in on one another. But I think that's where the innovation of our peer services and peer workers was so important in matching those peer needs. There were some really, really positive examples that came through in the surveys, where some people reported even, peers organizing Ubers with equipment and stuff like that, stuff that only I think peers can sort of do, because they only, they have that understanding of all of the difficulties and challenges that you're negotiating in those circumstances. But the isolation was a massive one, and that had major connotations for mental health. We saw rises in suicide, domestic violence as well, and major disruptions, I guess, to services. Do you know what I mean? Especially for people with chronic and complex care needs. Regional areas particularly suffered, and housing was another major issue, especially for places. I know I've mentioned Northern Rivers a few times, but because of the fires, COVID, and then the floods in 2022 during the tail end of COVID, the housing crisis there was absolutely massive. And I know in other parts of Australia, that sort of also played out, and definitely added to people's vulnerability, even more so. But as Ellie mentioned, the way that our services were able to adapt and innovate was, a credit to them, I think. And in terms of addressing, some of those distinct practical gaps that affected even more, our community, for instance, the issue of smartphones and that sort of thing. I think Karma had an initiative where they were helping our peers access, smartphones that could actually do the functions that you needed for check-ins and those sorts of things, because, that was obviously a massive barrier for people. So, I think, and another issue I think was the fact that, a lot of the funding and the responses were time bound, but people's needs, continued on beyond, well past COVID, and the cessation of lockdowns and so on. I think there's even still, a flow-on effect to an extent. But yeah, I think there's definitely a greater sector and public awareness of the need for not just public health, but for like forward planning and preparedness in this regard.
Yeah, thanks, Jess. And some really good points. Yeah, that Karma example of providing that real practical material support like smartphones and data was a really good case. It was a really good example of just meeting those making sure people had equitable access to get information, to check in, to even access digital health services. We need to be looking about who's missing out when we go digital, and what we're assuming about people's access requirements. I'm interested just to take a bit of time to talk about with both of you about adaptations to ODTP or the pharmacotherapy, because there were, what we found out was, and from our own experiences, was that there were like kind of big changes that made improvements to the way that people receive their medicine. And yeah, so do you want to maybe Ellie, do you want to start with like telling us about some of the changes?
Yeah, sure. Yeah, so our community was really found that some of the changes that were made to the provision of methadone and buprenorphine meant that they didn't have to go to a pharmacy every single day or a clinic every single day. So there was an increase in most states and territories where you could get more takeaway doses, and especially if you were sick and needed to, and that someone else might be able to pick up your doses if you were having to isolate. And because these programs are normally so restrictive, and some states are more restrictive than others, it gave people just a lot more freedom around their medications that was like it was good for them. We found across the country that there weren't adverse outcomes. The reason that a lot of these medications are so restrictive is that there's an idea that we will misuse them and overdose, or give them to someone else and they'll overdose, that there's a risk to us being able to use them the way other people would get their medications. And we didn't find that when when there was more flexibility around people being able to get extra doses. Uh, it never got to the point where it was the same as most medications, especially with methadone, but it was just a bit more free. For most people, you could get longer scripts as well. You didn't have to go to the doctor every second week or every month. You could get maybe even up to 6 months of a script, and get and do telehealth and things like that. Those things were really beneficial, even if you were isolated in other ways and locked down. It still made a difference to how people felt, in terms of being less stigmatized. It also meant that when you don't have to go to the chemist every day, you are less at risk of getting COVID in the first place. So you're less likely to get sick if you're not having to go out in public, take public transport to get to the clinic or the pharmacy, and dose in a public place and all those things. So less stigma, less COVID risk, and greater well-being for a lot of people, and no greater risk to us and our families and friends. Unfortunately, what we've seen since then is that it has gone back in almost every state and territory except Victoria. And so we're back to some states having just 4 takeaways maximum per week, which, if you're on methadone, which means going to the pharmacy 3 times a week, which, when you think about it in that sense, is like just outrageously restrictive for people just trying to live their lives and go to work and look after your families and whatever else. And there's no good reason for it. So that was one of the major ones. For us, I feel like I'm doing all the talking though, so I should
That's
let.
okay. Yeah. Thanks, Ellie. Yeah, Jess, one other theme that sort of came through with the ODTP, sorry, was the importance of kind of like good relationships with the pharmacy, particularly in the beginning when there was a bit more uncertainty. Do you want to talk about some of those aspects?
Oh, look, obviously it's individual based.
Of course.
Yeah, some people, whether dosing through clinics or community pharmacy, living in a regional area during COVID, at that stage, thankfully, by then had transitioned to a community pharmacy because I was traveling nearly 2 hours to Lismore each day to get my morning dose, like between, within a 3 hour dosing window. Like, so once I got to the community pharmacy, that was a lot better. But I think unfortunately it's really it's a very individual dependent, the relationships are important, but it's also very contextual. And I was really lucky with my pharmacy, and I think, like in the case of the Riverlands Clinic as well, they were sort of proactive in saying, no, look, everyone gets takeaways. Like, they sort of took that step of authority to say, look, this is what we're doing. And it was interesting. My chemist sort of did the same. I had an instance where we had the floods, and I just, we didn't I couldn't get there because we were flooded out for 2 days. And then when I could get in and there was more rain coming, I just got handed basically a whole week's worth. Just go. It was interesting. People took the authority to make calls, in a different way. There wasn't as much risk aversion, and the sky didn't fall in, like Elle said. Like, guess what? People are actually capable, self-determining beings. You know what I mean? Yeah, it's and I think the disappointing thing is that those findings haven't been absorbed and carried over, into policy the way that they should. But some of the recommendations, I think, touch on some of that. But yeah, I think it was really site specific, relationships specific, people's experiences. But I think on the whole, services and providers did seem to step up, and in my experience, they were standing up for our community, which is good. So we need to see more of that, not just in crisis situations.
Yeah, and we also had some participants who were reporting that, because I remember a couple of quotes that we've put in the report.
There were
Okay,
some people who were
yeah.
saying, like, they never thought that they would ever be able to have, a friend pick up their doses and bring it. Like, they're just mind
For
blown that
example,
that would
yeah,
ever
great
even be,
example.
possible. It really shifted the goalposts.
Thanks. Was there anything either of you wanted to talk about, the kind of the personal impacts or adaptations, before we kind of move more into a systems approach? Do we have any? I just want to remind participants that if you've got any questions or comments, to put them in the Q&A function. We'd be happy to answer those as we go along. You don't have to save them all for the end of the webinar, because we might run out of time.
I think by the time we did this report, the research, it was a couple of years after COVID, and a lot of people were so sick of even thinking about it that they didn't even want to think about it. But that, like, the ongoing mental health impacts for people who were isolated really came through from, I think it was traumatizing for a lot of people. And that included people that were given housing in those situations and lost some of their networks that they had when they didn't have housing. Because like, you might be put in a hotel and restricted, your movements restricted more than ever. The lockdowns that happened in the high rises in Melbourne were pretty serious for the people that were impacted by those. And so some of that stuff really came through in the way that people talked about it. And even on the ODTP situation, on the dosing stuff, if you weren't fortunate enough to be in the place where you got those, where your pharmacist or clinic was giving you a bit more flexibility, then you're like, you're more visible to the police. You're so much more vulnerable. And that stigma, I think what you were touching on, Joelle, that stigma, like even if your pharmacist or prescriber isn't trying to deliberately stigmatize you, you feel it and it impacts on your relationship with them. So some of those systemic things have an impact on your individual relationships and your ways of existing in the world and how you feel about yourself and those things. And I think, yeah, I think that came through in the report quite strongly from this crazy experience that we all went through.
Thanks, Ellie, for highlighting those systematic and structural things that impact upon that individual level, and it's not necessarily individual's fault that there's not a strong relationship there, because it takes two people in a relationship, and stigma. I've seen it myself, having a different chronic condition and picking up meds from pharmacy, and people waiting for their doses, getting like put last in line, even though they've been waiting longer than me. And yeah, like I think just like small actions like insisting people get served in the order that they turn up is like probably a good place to start. Yeah, okay. So and look, as well, I wanted to, sorry, before we moved on to the next thing, there was another point about the mental health stuff. People who didn't experience like mental health ordinarily reported experiencing, bad mental health for the first time, as well as kind of forgetting how to like being a bit socially anxious, like, and being out of practice of socializing and connecting with other people, and or reporting that their friends, that their friends have continued to isolate. Maybe they're still worried about COVID in the community because it's still occurring, and maybe there's a whole range of other factors that kind of impact upon that. But reflecting on my own experience, I definitely forgot how to like socialize and how to have conversations in groups and all sorts of things. It was really awkward at first. Uh, yeah, okay. And so maybe we can start talking about some of the policy and system stuff as we interrogate some of the key recommendations for the report. Does that sound like a good place to go with the time that we've got left? Yeah, great. Okay, so first of all, maybe we will talk. I have gone through and bunch these together and categorize them a little bit. So I thought maybe we could go through I think there's 4 themes. So the first theme is about involving people who use drugs in climate and health disaster planning and preparedness. And so, what are some of those what is some of that high level planning that governments need to ensure that they're thinking about our communities, they're consulting our communities?
I think it like starts with conversations like this, and I think it's also about taking integrated approaches to. I think we learned. I think it was a clear learning was the way in which like there was a siloing of services, and connectivity and navigation became even more challenging than what it typically is for people with complex needs. And I think basically I think people who use drugs and our respective peer drug use organizations in each jurisdiction, I think at the state and territory and the national level, need to be involved in and invited to government conversations and policy considerations. There's so much forward planning and learnings that we can take from these experiences, and not just COVID, from the fires, the floods, like for instance, equipment. Like one of the things that all of the services consistently reported was the massive strain on equipment availability, and the need for some sort of government forward planning, around to expect that there is going to be, obviously in a pandemic, we saw shortages of various things. I remember at one point tattoo parlors were donating gloves to hospitals and that. Like, expect that there is going to be a shortage and plan, to have reserves for medical supplies and those sorts of things, and making sure that the most vulnerable have access. And I think a human rights based approach is fundamental in that way too. And ensuring that the most vulnerable parts of our community, Aboriginal and Torres Strait Islander people and leaders, pregnant women, our LGBTIQ community, the people, the homeless community, the people who, are often the most visible and the most harmed by things like this. Yeah, they need to be. They need to be the ones in these conversations. Sorry, just wait.
That's all right. You could do that. Billy. Don't worry about it, Jess. This is what happens when we have families, and that's like completely okay. So yeah, thanks for thinking about those critical supply chain issues that were experienced, not just in our supplies, but yeah, the PPE as well, and some medicines, and the need for government to be planning for that and involving us in those planning decisions. Ellie, did you want to add anything to those points about this theme about involving us?
Yeah, I do. Yeah, so like there was a lot of work that went into looking at the learnings from COVID-19, and that the Commonwealth did reviews, the states and territories did reviews, and we didn't see anywhere that we were a priority population. So our needs weren't factored into those conversations, as far as I can tell. When we do have like unique vulnerabilities and stresses, we have an aging population of people, sometimes and often with chronic health conditions. And so we do need to be at the table when they're doing the reviews, when they're doing the planning. We have an Australian CDC, the ACDC, that has some community involvement, but again, like, we might not be the people at the table there. So I think that we've got these really strong organisations at the national level and at the state and territory level that should be resourced to be part of those conversations and included in them whenever we're doing any of the looking at what we've learned and planning for future activities, because we do have some unique needs.
Thanks, Ellie. Yeah, I just want to add a comment here from Candice. So many got housed in inner city Sydney. People lived well using the MSIC due to increased New Start and more funds and more access to takeaways. Actually came in with food as they could live better on the increased social safety net. But then many got massive fines for moving around, just going to the bank or the ATM, or going around to score for violating public health orders. But a lot of fines had been waived, but it was a shame because that kind of caused stress at the time, which I can imagine, really stressful to be involved in law, any kind of like law enforcement during a time where everyone's already,
Yeah, and on that point, Dr. Shelley Walker did a whole lot of research around the COVID fines and found that people who use drugs were more likely to get fined, got higher fines. Their reasons for being out, like going to the clinic to get takeaways, weren't believed. Not takeaways, to get dosed and get their medicines, they weren't believed. Even if they had evidence, the police weren't necessarily interested in looking at it. So there were people who got like multiple like up to $6,000 fines. And
Yeah.
we've included that in the report, some of those findings that
Yeah, more for people who are Aboriginal or Torres Strait Islander, other people from multicultural communities, based on racial profiling. It's kind of really shows a really kind of the horrid side of the whole affair. But what Jess said was like the sort of centers the importance of a human rights-based response when we have health or climate emergencies. Okay, let's. Sorry, there was a question before we move on. There was a question about pharmacotherapy that someone asked that I thought might be good to answer. The question is, Jess, as though seeing as you got your chemist allowed more takeaways due to COVID, have they gone back to the allocated amount? And is that because of possible fines for the pharmacy? Who governs or makes those decisions? I thought that's a really great question.
Yeah, so I think it is state based, the like how state and territory based how things are regulated. And sit with me. And so in the instance where during the floods when I got more than, at that time, what was my allocation, that was a one-off. And I but during that time I did have my takeaways increased though to the maximum permissible amount in New South Wales, which was 6 during COVID, and they have tried to wind that back in some cases, but it's at the prescriber's discretion, more so the chemist's discretion, the takeaways. And I know ACT, there is, because I think they've been a bit more strict in winding back people from 6 to, I think, 4. I think there might be limited instances of 5, but they sort of have been a lot more stringent. But New South Wales, it seems, I know a fair few other people who seem to be on 6. It seems like it has been, while it hasn't been sort of entrenched in policy as a standard, it seems to be sort of among prescribers,
Practice.
More of a sort of more practiced. But yeah, it's the chemists. I mean, some chemists will be, I think, the chemists that I've encountered who will make those calls, about, who have that, authority and confidence. They'd been operating for 30 years. So I think that they had, younger chemists I find will be a little bit more risk adverse. And I have encountered some chemists too who say that, look, we've had the prescribing, authority, New South Wales, come in and come down on us. And yeah, we're being really stringent now about everything. And, so it is very site specific. But ultimately your takeaway limit will be set by your prescriber.
Yeah. And then there's guidelines, national guidelines, which are a little out of date, and then state and territories have their own guidelines that kind of inform.
But there is
the practice of
a large scale research project that's been funded, which is involving sort of a national review of Australia's OTB. So hopefully we'll see some improvements.
Yeah. And it makes a really great segue into kind of the next theme of the recommendations, which is around expanding flexible models of care. So there were things like telehealth, as well as what we just discussed with ODTP, which there's opportunity for our networks to be advocating for expanded flexible models of care, because the evidence for winding those back just isn't there. And then, of course, like investing in our peer-based organisations and services for people who used to use drugs. Do you want to talk a little bit more about that, Ellie?
Sure. Yeah, so what Jess has been talking about a little bit, and you also, Joelle, the need for our organisations to be resourced before something happens, so that if there's disasters in our local areas or at the national level, another pandemic or those kind of localized fires and floods and things that happen, that we're able to respond really quickly, so that we can have the stocks available of equipment that we need, the PPE, whatever it is that is needed in that kind of local area. But especially the workforce, like increasing your workforce all of a sudden is hard to do, and giving people the training and that kind of thing, like it needs to be done in advance where possible, and regularly. And our organizations at every level, we know they're incredibly under the pump and operating with fairly minimal resources most of the time. So that was a really strong recommendation that came from the people that we talked to and the consultations that we did. And it, like, the work that they did during the pandemic really showed that it's worth that investment, I think.
Agree. Yeah, the impact was definitely demonstrated, and the value on, or the return on investment, if you want to use a purely business term. Yeah, thanks for talking about those, the impacts on workforce, as well as like preparedness for the community. Like, you don't just suddenly have the knowledge you're in the middle of experiencing a flood or have to evacuate because of fires, and you
that's
don't.
something that came out too.
Yeah.
The need to
Jess,
build.
do you want to talk about that? Yeah.
Yes, the need to build, sort of like invest now, in building workforce, not just knowledge and understanding, but confidence and competency in operating within, a disaster environment, whether that's, climate or otherwise. And to, I think, something I was just going to add to what Ellie was saying is just the importance too of governments and funding, matching the full extent of needs. Just because the official crisis, or lockdowns have ceased or whatever, it doesn't mean needs cease, and funding needs to be provided for as long as those needs exist. And I think there's a lot of people who are left in the lurch in those sorts of ways. So,
which is a really great segue into the next series of recommendations, which is our addressing social determinants of health and equitable access to digital services. And I think that talks, it's kind of like, if people need housing, give them house them, or support them to maintain housing. If people need a smartphone to access a government app to get a service that they need, then give them a smartphone. But I think a little bit of it is like funders enabling, or like, the funding has to come for the, to allow those things. Otherwise, we're just doing it off, self-earned income, and it can only go so far. Was there anything? Okay, and then the final one was around building the capacity of our peer workforce and emergency services. So we have talked a little bit about that in terms of like having the workforce prepared for when pandemics or climate crisis happen, but also important stigma and discrimination and knowledge for first responders, so emergency services workers and volunteers as well. not forgetting the incredible work of like the SES and the volunteer fire
I think it sort of
associations
picks up
across this
on what
country.
Elle was saying before too about, like our community needs to be considered within all of those, frontline responders planning from the get-go. We shouldn't be an afterthought. All people working, in frontline health and social services should, be appropriate and capable of, dealing with people who use drugs in an overdose situation or, whatever. Yeah, like,
And
You know,
people shouldn't be forced into withdrawal, like withdrawal, or be put in a life-threatening situation because they can't access what they need.
I mean, even like with the when they with the Lismore floods, like they couldn't even helicopter like people their meds, because apparently sometimes they do med drops, but they couldn't even do that because the helicopter was flooded. Like they didn't even have a helicopter. It was a mess. Yeah.
All right, so we're now we've had other members of the audience reflecting that they've had similar experiences with their OAT in New South Wales. We've got probably about 8 minutes left, so I'm going to start bringing the conversation to a close, and perhaps we'll finish by sharing some final thoughts. Jess, did you want to lead on, some key takeaways or your final thoughts? Anything you didn't get to say?
Oh, look, I think it's been a really great report, and really thankful to all of the members for supporting, and the engagement of peers on the ground, and making it an actual meaningful localized feedback process. I think that there's a lot of substance, and key takeaways that we can certainly be not just building on, for our own, planning, but certainly as advocacy and lobbying points. I think there's certainly room for improvement. And yeah, I think be exciting. I think there's definitely an article, probably in this as well. I think as as the AIVL research lead, we're investing a lot of energy as a sector toward growing our research capacity and capability, and our research program. And this is, one example of that. And it's sort of, I think, the key next step to me is using this evidence now, and the direct feedback of our community to really get some traction in state and territory and national, future planning and response preparedness. So yeah, as I mentioned, when it comes to all manners of disasters. So yeah, I think even local governments and things, and engaging with our cross-service partners and getting this out there, I think that'll be also really valuable. So yeah. But thanks, Joe.
Thanks, Jess and Ellie.
Yeah, I think we learned a lot from COVID. We learned things like that. Well, I think we knew this already, but police aren't the best first responders when it's not a police matter, especially health is not necessarily the thing they do best. That there's as much money available as you want there to be. That the government can find money if it wants to, and it did during that time. And it could again if it wants to. So I think the things that we're asking for aren't outrageous and would be beneficial for the whole community, not just for our community. But when you've got, well-being and health and, safety for the most vulnerable people in your community, it's a better community overall. So yeah, I think this report is important for us and for others to be looking at. And I also wanted to thank all the people that gave some input into it, the people from our member organisations and their members who completed the surveys, and especially you, Joelle, and Leah, and other people at AIVL who really finalised it and made it the great report that it is. Jess did so much work getting it to that point as well. And so yeah, thank you so much for creating it, Sam, for making it look so pretty. And I really hope it is useful for people to be able to take and use for advocacy for our community around Australia. Yeah, thank you.
Thanks so much, Ellie. Yeah, so the report is going to be circulated, like the links will be circulated when we share the kind of wrap up the recording, and we'll have the full report and some different summaries available. So yeah, we look forward to you receiving that and providing we're open to feedback as well on that. But yeah. Thank you for coming today, and we hope you have a wonderful rest of your week. Take care.
Thanks. Bye.